Hey everyone, OT Lifehacker here. What is it like for an occupational therapist in the hospital setting? Well, I just came from fieldwork at a hospital, so I can tell you what I know from my student perspective. Ding ding! Skills that you need as an occupational therapist in the hospital setting. A lot. The end. No. So you need a lot of different skill sets. Communication for sure. And being able to adjust your speaking, your tone of voice, your demeanor to the client, because know again that when the client comes to the hospital, there's so much that they are transitioning in, that they're going through. They've just experienced a loss of independence and of financial problems with having this unexpected not able to work, having this disability or at least inability to do what they used to do. And there's a huge amount of grieving related to the fact that things are so different, and it's different for their loved ones. They may not be able to live with their loved ones for a while. There's a lot. And I'm sure that for those of you who have had that experience, being the patient yourself, you can understand this. And if you feel comfortable, feel free to share your experience as well in the comments below, because hearing a person's perspective on what they've experienced really hits home for many of us, because it makes us aware of what it's like for someone to go through this and how we can be more compassionate and more helpful to someone else, because that's essentially what all of us want to do. Our goal is to be there for someone, help them through the challenges they're going through in the way that is most effective to that person. So if you can tell us, share with us what you've experienced, that would help everyone a lot. And in the hospital, communication along with verbal communication as well as written communication, because you're going to be doing a lot of documentation, especially if you're the occupational therapist in charge. Tons of documentation to be had. Granted, it is the electronic medical records now, so you won't have to be writing by hand, but you still have to type. You have to have the correct grammar and correct spelling, keep it professional, right? And there's a lot of boxes to click in and out of, so you have to have that skill with using technology, the computer, something I'm going to have to work on. And being able to communicate with all the other disciplines in a respectful and professional way, and handle conflict resolution. Conflict resolution skills are so important for OTs, occupational therapists, all other disciplines, and working with the patient. You're going to have patients with completely different personalities, and there may be even other conflicts that you have with them. And so you have to figure out how to work around those. And even today, with one of the clients, the first client of the day, it was a different, very different communication style to be had, because their communication style was very different. So you need to adapt your communication to fit there. So that, I mean, you don't have to, but it can be much more comforting to them to know that there's a familiarity, a commonality between you two. And it can start with how you present yourself. And medical terminology is a big one in the field. There are so many times I had to step back and think, what is that term? What are sternal precautions? What are spinal precautions? Or all the other heart precautions? There's a whole bunch of things you need to know in the field that is medical. You have to know about the appropriate oxygen rate and high blood pressure, orthostatics, and the optimal heart rate, and know different conditions, and at the very least, basics on the different conditions, like what causes them, how they're treated, And it'd be great if you knew the medications and side effects of the medications, and that's what I am definitely working on, trying to figure those out. There are some medications today that I didn't know, but you see a pattern in some of the conditions that are occurring for different clients, and they have a similarity in reasons why they're there, or just like something that you observe that's the same or similar. But again, know that every patient, every client is different, and so adapt to that client and that setting, and above all, be present. You are there for the client no matter what. Just the idea that someone feels they are being heard and listened to and cared for means more than anything. In the hospital, in any setting in the world, it means so much to a person. So please just be there for the person and show how much you care for them. Formal assessments that are often done by the occupational therapist, or even the COTA, the Certified Occupational Therapy Assistant, in the hospital are cognitive assessments such as the MOCA or the SLUMS or the ACLS, which is a leather lacing test. And I have a video on that if you're interested to learn what is the ACLS. Well, feel free to take a look at one of those at my video on the ACLS. To see what needs to be worked on for the client is done through functional observations by the occupational therapist. That means observing the person doing the activity, whether it's washing their face or walking, getting in and out of bed. There's so much that you learn about the person's skills simply by watching them do a task. And now there's also the assessments where you can see after you do those functional assessments, you may think, okay, so it looks like this person has trouble seeing their medication, or seeing the toothpaste and opening it. Let's see if it's a visual problem. If it is a visual problem, that's why they're not able to open the toothpaste. Or is it that there's cognitive issues, or is it motor problems that they don't have the grip strength or the strength to do that? Or again, cognitive, is it that they're not able to sequence the steps, you remember what they were just doing, or a whole slew of different possibilities for concern. Occupational therapists provide treatment, different interventions to help with doing self-care in the hospital. So that can be anything from washing your face, getting up out of bed to the sink, and then washing your face and brushing your teeth and going to the restroom, dressing yourself, putting on your pants or your shirt, and combing your hair, even practicing getting in and out of the shower that is there in the hospital. But one of the key things that the therapist will do is they will try to make the setting as realistic to the person's baseline setting, meaning where they lived before the hospital and where they're going to return to eventually, or potentially eventually. And so many times, say for example, if the person has a bath and not a shower, which you'll find a shower in in the hospital setting, the occupational therapist may improvise. They may grab a trash can or something that is the height of the bath lip and put that in front of the person has to walk over it. If the person doesn't have grab bars in their house or bathroom in their own home, then they will have to they are recommended to not use the bars in the bathroom in the hospital and enact as if it's their own place. And so there's a lot of things that are considered, and we want to, again, the transitioning out of the hospital is so important to be teaching, to educate the clients on how to live independently once you're out of the hospital or the next setting when you're at home. So having it be as natural, as familiar to the client is very important. The schedule for going to see the clients is highly variable. Again, multiple factors in the hospital setting, completely dynamic setting. So you may walk into a room and the person may be getting dressed or using the bathroom, the commode, with the physical therapist and with the nurse. Or the nurse may be doing their medications or giving them shots. Also, you may walk into the room and the client says, "No, I don't want therapy, I'm about to eat." "No, I'm still tired, I'm not ready for therapy." Or simply, "I don't want therapy, get out." You roll with the punches. So you can coordinate on the spot with other therapists when you're going to see the client, or just try to see if the client's ready and able to do the activities with you. You also have to consider, so even today when I went in with my supervisor, who's an occupational therapist, we had gone to the ICU to see a certain person, and that person seemingly had been discharged without us knowing, without my occupational therapist knowing. So she needed to reorganize her schedule for whom she was going to see, and there were many different things she needed to look at to see who she could go visit. She considered the conditions and the readiness, contacted different people if she could go see that client. Lots of things that you have to remember when you're in the hospital. So many different responsibilities you have. It's amazing. It's absolutely amazing. We learned about appropriateness. Is the client appropriate? And that can be anything from how is their level of functioning? Are they their level of functioning and awareness and their current condition, is their condition okay for them to receive therapy at that time? You also, in junction with the records, electronic medical records and documentation on the client, you also need to double check with the nursing or physical therapist who had seen them prior, anyone else who had seen them prior, and check to make sure, is everything okay for me to go in right now? Because in the hospital, you may not know if the client is being seen by someone else, or even if the client is ready to do therapy. When it's time for the occupational therapist to do their session, whether it's the evaluation or the reassessment or the treatment for the client. Now also, there is another video that I have on what the occupational therapists and certified occupational therapists do in the setting. Do for their roles and responsibilities, delegation of tasks, supervision. All of that good stuff is in my other videos, so please feel free to check those out for more on what the occupational therapists and COTA do. And so the occupational therapist can do all three, the evaluation, reassessment, and treatment plan. Most times the certified occupational therapist focuses on treatment and assessments. However, they can help in informing the goals for the client, what the new goals will be, and the evaluation, implications from the evaluation, because again, they work directly with the client, so they have excellent input to enhance the care. So the therapist and the COTA before they go into the client's room, it depends on what works best for the clinician, but many times I've observed the therapist goes through the charts, the electronic medical record. They'll look through the chart for the client, look at the different other providers who had seen them, like the physical therapist, nurse, social worker, physician. They'll take a look at all of those records and see what's pertinent for them. And many times, again, our focus is what was their baseline for all of their activities. Were they independent, or what level of assistance did they need when doing grooming, bathing, dressing themselves? What was their living situation like before? Did they have support from others? Did they live by themselves? Did they live in the community? How many stories is their home? Because its mobility is going from one place to another by foot. Is that going to be a challenge for them? Do they have assistive devices like walkers, wheelchairs, canes? And what does their bathroom setup look like? Do they have grab bars? Do they have the non-skid mat in the shower? Do they have a shower? Do they have a bath? There's so much that is considered, even down to the bed. We look at, is the bed going to be hard for them to get into, hard for them to get out of? Is it a fall risk for them? You may look at this because take into account the sturdiness of the bed, if it's well cushioned or if it's a hard bed, what the height is for the bed, because if you're sitting very low in the bed, it may be hard to get up, or if it's just a little high, it's less exercise, less work for you. And they also look at they look for if there's been any changes in their level of care while being in the hospital as well, because in the hospital, it is extremely dynamic. Things change rapidly. A person, you may come into the room and they may be vomiting, they may be nauseous. You may have to immediately change your plans of care. The occupational therapist has a lot of meetings that they may have to attend throughout the day, and the interdisciplinary meeting is one of them. They may also have a meeting within just the other occupational therapists they work with, or even within the therapy team, and that can include the speech and the physical therapy group. And now keep in mind that at every place it is different. There's different culture, different politics, a lot of different factors you have to consider. And so do share with me and with all of us what it's like in your setting, for the hospital setting. What is your experience like? At the interdisciplinary team meetings, all the different providers share how the client is doing from their perspectives, from meeting with them, because all of these people are involved in the client's care and see the different perspectives. So this meeting allows them to bridge all the information they have and create a very essentially to bridge gaps in information and really make for the most effective and efficient care. Now, the goals in the interdisciplinary meeting are, as I said, bridge the gap and make sure everyone is on the same page so that you can produce the most effective care, and figure out where they're going to, what their discharge plans are going to look like, what their plan for the rest of the stay in the hospital will be, and what recommendations, suggestions, changes to the care have been observed and need to be reported. And discuss if any new therapies may be needed. In the hospital, there is the interdisciplinary team which does rounds, and at these rounds, it has different disciplines within the hospital setting. So that includes occupational therapy, physical therapy, speech therapy, and the healthcare provider, whether that be the MD, DO, or nurse practitioner, physician assistant, whoever is managing their care, nurses, of course, and social worker, and any other fields, any other staff, health professions involved. And although, I haven't really seen pharmacy in there. Does pharmacy go to the rounds at your hospital or wherever you've had experience? Please let me know in the comments below. That'd be interesting to know for me. The goal for occupational therapy in the hospital setting oftentimes focuses on transitioning the person to the next level of care. So a person had just undergone a major surgery, had a major accident, major injury. The hospital is the first place they will be taken care of, right? Then where to next? So the hospital is essentially a place for transitioning that care to the next level, whether that be in a skilled nursing facility, inpatient rehab center, the home, assisted living, or foster home, wherever the person's home or next place should be. And in occupational therapy, who do we see in the hospital? We see people with multiple conditions. It varies dramatically. Now, the hospital setting you work in could be different. If it's a bigger setting, you may have different departments. You may have a neurology department that sees a lot of brain injuries, such as traumatic brain injury, and you may see a department for cardio and pulmonary, so for the heart and lungs, so that might be pre and post surgery for the heart, or people with particularly chronic obstructive pulmonary disease, which is COPD. And then you may see orthopedics for hips and knees and back problems as well. And then there is the there is the ICU, the intensive care unit, that can be for those who have very, very intense, serious challenges. And there's so much more. So in the setting I am currently in, it is a smaller hospital, and so they are altogether general medical surgery, med and surg, which is, they have everything. They have people who have just been admitted to the hospital for a major injury, for an injury, for people who are going to undergo surgery, who have undergone surgery, who have fallen. It's a whole slew of different conditions. Now, the common theme among all clients so far that I've noticed is the comorbidities to start with. So many of the clients that come in, they have one core reason they're in the hospital. You don't get admitted unless there's an emergency that you have to be admitted into the hospital and stay. And so these individuals oftentimes have so many different issues that are in their history, their medical history. And that can be something from COPD, diabetes, hypertension, kidney disease, or past history with cancer, past history with surgery, autoimmune disease. It can be anything. that's oftentimes what is there in the hospital.